The views and opinions of our guests are personal and do not represent their institutions or Applied Prevention Science International.
Okay. Go ahead, Maria. Maria, did you want to say something?
Oh, I just want to welcome everyone. Thank you for signing up. Thank you for joining. This is a very exciting conversation we're having today. We're having Zili, APSI president. I'm going to ask you to please mute your microphones while we are doing the presentations, and then you'll be able to unmute yourselves when we begin the discussion. So thank you everyone for being here. Giovanna, I think you need no presentation, as well as Gregor, because we all know who you are, what you work with, and we are very happy and proud to and honored to have you here today. So please start.
Well, welcome to Prevention Talks. As many of you know who have been following us, that APSI has been trying to put together one talk a month on a significant topic. This month, today, we're talking about, and in February, we're going to be talking about professionalization of the field. Our next presentation, prevention talk on professionalization, is going to be on February 11th, again at 2 o'clock. And we'll be talking about workforce development. We have Tracy Flynn from the, this is very United States oriented, but I think it has implications internationally. Tracy represents the, in each state in the United States, we have a person in charge of prevention, and she represents those people and she organizes their meetings, etc. And then we also have from the ICNRC, we have Julie, just going blank. Julie Stevens and Sandra Del Santro to talk about what's going on in the credentialing area, because there are some changes. So which brings us up to date what's going on. I suspect we may have some more related talks over the course of the next year, but we have these two set up right now. What I wanted to sort of set the framework for the presentations of Giovanna and Gregor. And I don't know, many of you don't know that I have my bachelor's degree and master's degree in sociology. And I've always been very interested in sociology of professions. And so when I was thinking about workforce development and thinking about professionalizing the prevention field, I went to that body of literature to find out, how do you define what a profession is? And I must say that there's lots of information. What I put together is what we see before us, is to establish a profession. There needs to be a systematic body of theory. There needs to be competencies. There needs to be knowledge, a skills base, etc. That are specific to that particular profession. There needs to be some authority to define what the problem is that you're addressing and how to address that problem. There also needs to be
por favor.
there
baja volumen.
There also needs to be sanctions in place, so that that we define who that professional is. They need to be credentialed, and in many cases licensed. There needs to be an ethical code of conduct that stresses the ideal of the services to others, and there needs to be a culture that is a number of institutions that are created that actually carry on these functions. We finally have gotten to the point in our field where we finally have gotten a definition of what prevention science is. And this is, you can look at the dates at the bottom of the slide, and you can see how recent this is. The Society for Prevention Research in the United States developed what's called Standards of Knowledge for the Science of Prevention. This sort of shows the dimensions of prevention science. This was adopted by the European Union Society for Prevention Research, the National Prevention Science Coalition, and and APSI have developed the prevention definition you see on prevention science definition you see on the screen. The prevention science identifies the determinants of behaviors that protect or put at risk the social, emotional, and physical health of individuals, families, and communities. It identifies the processes as to how these determinants operate. How do they operate to either protect or make more vulnerable? And then it also identifies what strategies effectively intervene when trajectories are negative and reinforce those trajectories that are positive. So we have at least a definition of the science behind us. What's more in question is what we really don't have in place right now is the authority to define our problems and how to be treated. We have some efforts on this topic, as we see here, but we have no universally accepted definition of prevention itself. The one definition I have at the bottom of the slide from the United Nations Office of Drugs and Crimes is that prevention is the application of prevention science to address the health and safety of individuals through improving socialization processes to enhance self-realization and participation in society. And a number of international organizations have been part of that development of that definition and support that definition. So I think that's moving in the right direction. Again, we see here that there's no real internationally accepted guidance for prevention professionals as to what is evidence-based prevention interventions and policies.
Beşilliği olmalıydı ya
Could
şeyi.
you please mute
Esası da
yourself?
orada vaxtında gəlib düzəltmədilər, lənə. Özdən də var günah.
Nerede o? Kim dinleyicilik şeyden yapacağım?
Konferansdadır.
Okay, and so the one major thing
Aksaq da
we do
bundan
have
heç
in
bir
place
tanrışdan
is what Giovanna's going to be talking about, the international standards for drug prevention. It's probably on drug prevention. And then we have registries. We have registries here in the United States. An example of that is blueprints that most people in the field know about. But there's also the European Monitoring Center that Gregor helped put together. At the portal, there's a program exchange which provides information on evaluations of prevention interventions, and very systematically, very nice portal to look at. A number of groups have been working to put together the theory, knowledge, skills, and competencies needed by professionals in the field. And they represent, as you can see, both US and international agencies and organizations. And I highlighted the European Drug Prevention Quality Standards that Gregor's going to be talking about, and the international standards that Giovanna's going to be talking about. And we do have a code of ethics in place, and that stress the ideal of service to others. It's both in the United States as well as internationally through the European Drug Prevention Quality Standards. But again, these haven't been embraced universally. And we don't have standardized training or credentialing or licensing. Now, an attempt was made after the international standards were put together of putting together our APSI had put together the Universal Prevention Curriculum, which captured information and knowledge in the prevention field to date. These were done, completed in 2015, probably and updated in 2017, but they haven't been updated since then. And APSI has been updating it, and we've been actually putting together our own curriculum based on updated information. There's also no central credentialing or licensing organization. We have ICNRC that's used by many countries, primarily for treatment, not so much for prevention. In the United States, each state may have a credentialing and licensing program, but that varies tremendously. And of course, it varies up internationally. So we have lots of challenges ahead of us to professionalize our field. I think we're doing a better job of integrating research and practice as well as researchers and practitioners. It's nice to be able to talk to practitioners about research and they don't get up and walk out of the room, because that has been my experience in the past. And I think we're more ready to embrace a multidisciplinary nature of our field. And that I think in itself has been a challenge, because we have many people in our field who have different backgrounds, different trainings, and they're doing prevention. But we also have people doing prevention that would not call it prevention. So we have to pull everybody together so that we're on the same track. I would like to turn now over to Giovanna. Is Giovanna going to talk first? And I'm going to stop sharing. Okay.
Just give me 1 second to share my screen and find the presentation. I don't have any sound this time, so it should be fine. Do you see the presentation just before I start talking in the void? Yeah?
Yes.
Yes, we see it.
Okay, thank you, dear. So thank you, Zili, and thank you for having me. Before I forget, I wanted to add something to the presentation that I'm going to do, because it just came to my mind when Zili was saying that in many of these issues that she just presented, we don't have a commonly agreed terminology or something. Well, at least on paper, what I'm going to present to you, so the international standards, have been endorsed by all of the member states of the United Nations, so 193 countries, as a useful tool to promote evidence-based prevention. So at least on this, there is some agreement. As you will see, the tool is good, but it has limitations, of course. And so many of the issues that Zili has just raised very much stand. But I wanted to add this bit. But before we arrived at that point, there was quite a bit of work. And for us, the, oopsie, let me see if I managed to actually move this thing. Yes. The standards were a way to respond to questions that we were getting all of the time from member states that were coming to us and say, like, what do I do? What do I do if I want to improve prevention? That was one thing. And then the other thing was the fact that I was discussing with many people from all around the world that had this feeling that prevention was not working very much at all, was not effective. And that was in complete contrast with what I knew from the science. And so that's where we arrived at creating the standards, which are basically a summary of scientific evidence from all around the world of what works and what doesn't work in prevention. So that was, there is a lot more that should be done, but that was our focus. We had the first edition in 2013 and the second edition we published in 2018 together with the World Health Organization. And normally, I try to speak at least a little bit about how we develop the standards. I don't have much time now, but I just wanted to reassure you that we were not alone in doing this. We had more than 100 experts from almost 50 countries from all over the world that were helping us. And we did use a very systematic and scientific methodology to develop the standards. And we were really looking for interventions, for studies that were looking at whether, as a result of an intervention, less people were starting to use or less people were delaying the initiation of their use. So for example, we were looking for studies like the one that you find in front of you. This is the representation of a study of a program that you deliver when kids are very young. They are 2 to 5 years of age. And this study followed the kids until they were 21, comparing to other kids that did not go through the program. And as you can see in red, in blue, that is the group that went through the program. At 21, less people were using marijuana. There were less cases of teenage pregnancy, and there was more enrollment in college. So when I say in the standards that something has been found to be effective in preventing drug use and other risky behaviors, this is the kind of evidence that I am basing myself on. What did we find out? I don't have much time to go into details, of course, but I think I want to give you some basic ideas. Of course, the first idea is that really we need to expand our perspective on prevention. I see many of you are, long-standing practitioner in the prevention field. It will not come as news to you, but believe me, all around the world, there are many, many people that still think that people start to use drugs only because they don't have that information about the danger of drugs, and therefore prevention is about providing information. And we know, of course, that there is a huge and important place on providing information about the danger of drugs, but it's in no way the only factors. Parents are essential. They matter so strongly. School is very, very essential. Being in school or not makes an enormous difference. And these vulnerability factors interact with each other. This study, for example, tells you how adverse childhood experiences interact negatively, of course, with inequalities, which is a topic that has come up again as important, but has been there all around. Inequalities have always been there to make health outcomes worse. And so this first part of the arrow is not this simple at all. It's much more complex, and it looks more like this. And I'm very proud to show you this because, of course, this has been developed by Zili, who just introduced me, and to which we owe so much of this work in principle, theory, and idea, and implementation. And so here you can see how there are factors at all levels, personal, but in the environment, families, communities, and so on. And they interact very much with each other. This is a prettier version that I want to give just because it has been developed by our colleagues in the World Drug Report and really showed that balance and that interaction between vulnerability and resilience factor. But so if this part is the first part of the arrow is more complex, it will not surprise you to know that the second part of the arrow is much more complex as well. And prevention is not about only providing information, far from it. This is how it looks. These are all of the interventions that have been found to be effective in the standards, effective in preventing drug use and other risky behaviors. And as you can see, we have intervention at all stages of child and youth development and in adulthood. And we have interventions in many different settings with family, school, community, workplace, and the health sector. So we have more to do than we thought, but there are some very good news. Well, first of all, we have more opportunities to do good prevention, but also we know that the vulnerability factors that are at the basis of drug use at the personal and environmental levels are at the basis of many other risky behaviors. And this that I'm showing to you is very old research, is the research of Professor Hawkins and Catalano, but is still one of the nicest representations of how the risk factors, that's what they were called at that time, at the individual, school, family, and community level are common in various degrees to many different risky behaviors: substance use, delinquency, teen pregnancy, school dropout, violence, depression, and anxiety. And so the great news is that, of course, if you do good prevention of drug use, you are preventing many other risky behaviors. You're preventing mental health. You're preventing violent behavior. You're preventing unsafe sexual behavior and improving school performance. And of course, you are cost effective. effective. And here I'm presenting an old but very conservative and safe calculation on how investing in prevention has a lot of returns, because really we are supporting the healthy and safe development of children and the well-being of youth and adults by doing evidence-based prevention. And what does it mean in practice according to the standards? I'm trying to summarize here. I think one of the things is that evidence-based prevention starts as early as possible. In fact, the earlier, the better. And there are very good and effective interventions that can be delivered already in pregnancy, during infancy, and in early childhood. For example, the prenatal and infancy visits for marginalized mothers-to-be and until the child is 2 years of age. Or intervention for pregnant women, whether they're using substances or not. There is a lot that can be done to manage the situation in a way that results in the best health outcomes for mothers and baby and the development of the baby. And of course, if there are problems of substance use disorders, we refer to the guidelines developed by the World Health Organization in this field. Early childhood education programs are also very effective in this. These programs support the development of children 2 to 5 years of age in marginalized communities, and they help their families too. In fact, this study that I was showing to you before is from one of these kind of programs. And there is a lot that can be done also in primary school years. And I'm showing to you this particular example of programs that basically teach teachers techniques to manage their classroom better in a way that makes it easier for children to learn. So everybody gains, but the greatest thing is that if you follow these children until they are much older, like when they are 21 years of age, you will see a much lower probability of substance use and many other risky behaviors, even for very at-risk children, like children that were aggressive in primary school. And doing this with no stigmatization at all, because this program is delivered to everybody. So really, that's the second message. Evidence-based prevention is very much about the development of children more than information. Information is important, but really we are thinking about helping children grow healthy and safe. And so, as I was mentioning, there are good programs that develop the personal and social skills education. So, for example, they really help children cope with difficult situations in positive ways. Like in this example, this is the example of a session that teaches young children how to cope with anger and how to manage that. And then, of course, there is the entire field of parenting skills programs that for us are very, very important. These programs are the programs in which you teach parents be better parent, basically, in very fun ways and not stigmatizing, not judgmental, just giving parents those practical tips to manage situations in a positive and warm way, which means making the family the strongest protective factor in the lives of their children. The evidence is strong, and I will just show you some graph from our own experience that shows that these programs are effective in general, but also in very difficult circumstances. For example, this is our work in Honduras in very violent communities. This is our work in Iran in very poor communities. This is our work with Afghan refugees, both in Afghanistan and in camps in Serbia, again, where we have been able to support families to work better and improve the behavior of their children. We also we know that there is an indication that family-based prevention might be more consistently effective for boys and girls than other kinds of prevention. And this is an example, and this is another example from our work in refugees camps. But above all, parenting skills programs are also effective, and we owe this to the research of the World Health Organization, which has done systematic review of the evidences that shows that parenting skills programs are effective in preventing violence, particularly youth violence, and preventing child maltreatment. So really working for the protection and the development of children. And these programs are so important for us. We have developed our own programs that are in the public domain, and even resources for parents to cope with the stressors of the COVID-19 pandemic and other stressful situations. At the same time, sure, we need to develop children. It's good to start early, but it's never too late. And in the standards, you can find many examples of prevention interventions that work for adults in adult settings. Of course, a lot of environmental intervention, brief intervention, screening and brief intervention in various settings, and workplace prevention. These are the main two that I would like to bring to your attention, but there are others. The other point that comes out strongly from the standards is the need to use evidence-based programs as much as possible, or at least evidence-based characteristics. And I want to tell you a little bit more about this, using the example of prevention education for early adolescents, which is maybe the most classic kind of prevention that we do all over the world. So when we do this, and this is what we would recommend, we would still recommend to try and use an evidence-based program. So a program that has been found to be effective elsewhere. And of course, Zili already mentioned that there are a few registries, particularly Blueprint, but above all, Exchange, which is the recently launched European registry that Gregory is behind. And that is a global resource, or a resource of global usefulness by now. And of course, you don't get a program and you don't parachute it. And there are guidelines and resources for you out there to adapt an evidence-based program in a respectful way, which, how can I say, conserves its integrity and its effectiveness. And it's sort of like trying the dress. You try the dress first before to see how it fits before changing it, right? And this is the kind of spirit that we recommend and that we follow in adapting evidence-based program, and that we could really talk even more about. We are doing this all over the world and it is effective, but we also understand that there will be cases in which you don't have access to an evidence-based program. And so I think that you can use the standards to at least guide you in the right direction. So for each of the interventions that I was telling you about, in the standards you find characteristics that have been associated with effectiveness and characteristics that have been associated with negative outcomes. So for example, for preventive education, there are indications of what works in preventive education from the point of view of the content, of the delivery. And we also have very clear indication of what does not work in preventive education. And what you can do is to take inspiration, or you look at your program and compare your existing program with the standards to see whether you are in the right place, and you can try and improve, and eventually, of course, evaluate and see whether your program is effective or not. And you can do this, you can use the standards to do this with any of the strategies that have been found to be effective and that are included in the standards. So I hope you can see that there is some value there. And the last, of course, indication that I think it's important from the standards is the need to coordinate the work from many settings. This is a strength, but also, of course, it's not so easy to do in practice, but it's worth it. Look at this study, for example, that shows over a 6 years period how, of course, the non-medical use of prescription opioids has been prevented in the green line by a good school-based program, great, but is prevented even more if you add to the school program a good parenting program, which is the blue line. And there are many settings, you remember this, right? And you have many opportunities and examples of things to do for any of these settings. And it's important to try and coordinate the action of all of these sectors. It's not easy, but as I said, I hope you can see why it's worthwhile. And this concludes my my slides. I hope I've given you a taste of the standards and how I'm inspired to pick up the standards, read them, and maybe think, can't understand much, and then write to me, right? And or we can have a discussion on how you can use various bits and pieces that, or maybe something is missing, and because ultimately we are all in it together to support the healthy and safe development of children and youth. And I'm looking forward to be in touch with any of you that might be interested in collaborating. Thank you so very much. Over. I will stop sharing.
And do we want to are there any questions?
If anyone has questions, please write them in the chat.
Yeah. Okay. Gregor?
Okay, shall I already begin? Do we not discuss? Okay, I have a question to Giovanna. Giovanna, remind me, why did you not mention the level of evidence in the new version of the standards? I forgot the reason.
Because it would require an entire new level of additional level of research according to the standards required by WHO. Because once, so it's one thing, the standards as they are now, they don't really include recommendations. They are descriptive of, you see what the evidence is, and it's up to the reader to make his or her own conclusions as to what, you know, is the best for their situation. And also we only include the characteristics as, I just say, consensus of experts. To move to the level of evidence like we had done last time would become recommendations, and the kind of process that is required by WHO regulations to arrive at that was not something that I could sustain at that point. I am, of course, planning it for the next one.
Okay. So it's me then. Can you hear me well? And can you
Very
see my
well.
slides?
Yes.
So I had agreed to focus in my presentation on what do we do with these standards? Basically, how can we get from standards, from having these standards, to really changing something in the prevention cultures, as Silly would say, or systems, as I used to say until now. So we have the European standards, the European Drug Prevention Quality Standards, and they complement the UNODC standards in a way that the UNODC standards tell you what to do. The EDPQS, the European Drug Prevention Quality Standards, just tell you how to do it, so how to get it onto the ground. And they're even a bit older than the UNODC standards. The project where we gave just impulse, but was run by Liverpool John Moores University and the consortium of many people and countries in Europe, some of which are listening here. Started earlier, and this is basically the only slide I want to show you about it, because it's all things you know deeply and by heart, but it was necessary for the plenty of European different cultures and professional cultures to have something clear and bold and basic to tell them how to actually set up prevention interventions. So if you look into a prevention system, that's from another publication of ours about prevention systems. The blue ones are the elements of a system. The red ones are the mediators, kind of the things that make it work better or worse. And orange ones or yellow ones are the moderators, kind of. Are they decent alcohol laws? Are there decent tobacco regulations? What is the Gini coefficient? I mean, the level of inequality. What is the social capital in different society? These are things we cannot directly affect. That's why we call them moderators. So the UNODC standards help you to select the best interventions with the best evidence-based, whereas the EDPQS help you to use, they suggest to you to use the UNODC standards to select the best intervention, but also how to fit them to the environment, how to improve the cooperation with health, education in the community, or maybe even at a regional level. And obviously they help to improve the workforce, but they do not yet specify what is actually expected from the workforce. And after kind of all this happened, let's say now 10 years ago, when we launched, when UNODC launched their standards, the EDPQS were launched, 10 years have passed, but yet we have still these situations like that, where lousy interventions get a massive support. The jewel in the crown is this Czech revolution train. It's just a scare tactics with new multimedia approaches. It's an actual real train going on railways between Czech Republic, German states, another country, Austria, who want to have it, and thus horrible scare tactics of the old 70s. So these things not only exist, they get popular and more popular. It even made it onto the official website of the German National Drugs Coordinator as a noteworthy project in 2016. They took it out only last year because we protested. And why? Because politically spoken, it gives the impression that finally something is being done. So it has a visible prevention. Why we always say prevention, if well done, should be invisible. And these are people that make loads of money for simply visibility and claiming that they are the ones who do something. A stay of a train in a German city's train station costs them 40,000 euros for 3 days. So what have we been missing in a way these 10 years? I think we always assume too easily that the whole field is an empty one, which we have to fill with nice evidence-based effective interventions. And we did not look at the fact that in many countries, the field is already filled with a lot of sometimes murky operators who live from, let's say, suboptimal and or obsolete prevention approaches and make money of it. And they will defend this with teeth and whatever other tools they have, even court cases. And so if we go to countries and say, yeah, we have all that. These are all statements we get from member states. We have a lot of programs. They're good because they're popular, like the revolution train. Or they say, the very revolution train says that they are evaluated. But evaluation means that the kids liked it when they get out and that the parents like it and the schools. That's the level of evaluation that they have. So the field is full. And even Pompidou Group, which is the drugs prevention organization of the Council of Europe, they have the European Drug Prevention Prize, where the only criterion, the main criterion is innovation. It has to be innovative. So deadline is tomorrow. You will have time, submit your project. It just has to be innovative. No proof, no evaluation needed, no proof of effectiveness, not needed. It just has to be fancy. The very same, the German the German general health education, which is for the moment being the best equipped money-wise agency in the entire European Union. They fund projects only if they are innovative. So basically, half of the interventions that Giovanna just presented cannot be presented because they are too old, like the GBG, unplugged, because it's not innovative. We need something for modern young people. These are old programs. So this is the state of the art in Europe. And if you travel through Europe and hold speeches, the problem is professionals very often. Only in one country in the entire union, professionals need to be accredited, needs to show their credentials, and need to have done a certain number of specialized training hours in prevention in order to get access to use. But it's only one country. When you talk, you get, let's say, in Spain, you talk about regulation, they call you prohibitionist, or they call you fascist if you talk about social norms. The Austrians say still evaluation is unnecessary. We know it works. The evidence doesn't exist anyway. We can do whatever we want. Nudging and environmental prevention is manipulation. Manualization of American programs, for instance, like GBG, this is all evil because it doesn't respect the individuality of human beings. Indicated prevention is medicalization, and problem behavior is not an issue. We just treat them. It's not an issue for prevention. This is what you get. That's what prevention professionals in my continent think and feel about prevention. Then you have the big elephant in the room, which is the drug education. People always say, believe that prevention would be drug education. And the challenge, it's a kind of in Ireland and the UK, that's very frequent. Or the concept of informed choices. It is still officially mentioned in the Dutch national strategy, as far as I know. Kind of, you are informed, the choices are yours. Basically ignoring everything we know about developmental pathways, about problem behaviors. And then came one little game changer, something that had never happened before. In September 2015, the Council of the European Union, the highest organ of the European Union, set up a council decision. They are not binding, but they ask intensely member states to follow these decisions. It was set up by a group of very good Italian negotiators at the EMCDDA, the Italian government, the Lithuanian government, and something that never happened before, that the supreme organ of the European Union speaks about prevention. And they have used the EDPQS, the drug prevention minimum standards, the drug prevention standards, into some minimum EU standards on treatment, prevention, harm reduction, and the ones on prevention speak about that. Okay, doesn't sound exciting, but look clearly. The highlight is they want that every member state of the now 29 member states gives their professionals access to available evidence-based programs. The second part is that it's more important even, is this paragraph. I have again broken it down. The keywords are, these professionals need to have competent, they need to know theories, they need to be actually trained, and they need to be specialized. So it means we only give access to our kids to people who have actually a decent training in prevention. Because if you look at European studies, in all cases, people who do prevention have never been trained specifically in prevention. They come from other areas and learn prevention on the job. Nobody gets into the job knowing about prevention. And then comes the citation about work for accredited and recognized institutions. So it means also people or NGOs who do prevention should be scrutinized and checked and licensed and accredited or not. Basically, only one country does it to create a healthy competition and maybe improve what is being done, improve existing NGOs, or just let them go. So what have we been doing? Obviously, the evidence-based programs was easy. We always invested in collections of program, and our updated registry brings together all programs that we have analyzed in European evaluation studies. And because of the European evaluation studies, you see that the strengthening families programs is not effective. So we keep it because policymakers know it and it's famous, but it does not work in Europe. There is not a single decent evaluation that shows that it's better than business as usual, better than family services that anyway exist. But it has all the programs that have been mentioned by Joanna. But the other thing, this is the big challenge because nothing has ever been done in Europe in that sense. And that's why we took in an EU project with 10, 11 partners, some of them are sitting here in the audience, who adapted the big UPC by Zilli and her team into a very short, adapted European version of the UPC, of the prevention curriculum, with more European terminology and much shorter because people in this continent, they don't come for whatever 800 hours of training. They come 2 days, maybe maximum 5 days. So, and the other thing was who to target actually. Because what Joanna presented is the thing that is helpful for everyone, but it targets often entire national systems. And in Europe, however, as in a drugs field, you have to follow the money because strategic decisions are made at national level. There are these beautiful national action plans and so on. But the money and where it is being implemented sits mostly at local or regional level. Many countries, Poland, Spain, the counties and the municipalities have the money and have to spend it on prevention and do not know how. So we need to target people that make decisions and not frontline professionals because they can't do anything if their bosses haven't been trained. I call it the Sloboda doctrine. You need to train the mid-level, people who take decisions in the county or regional level where the money is. And it needs to be short because these people don't have money and they believe they know everything. You need to tease them, convince them that they don't know anything and that they spend 2 or 3 days so that they improve their funding decisions. Meaning, stop funding for useless interventions that they have been funding. And we call these people DOPs, decision, opinion, policy makers. And now, how does it fit into the system? Here, it focuses more the organizational level, the interaction with academia, on maybe to improve research and quality control and bring that onto the field. And on the long run, also to improve the moderators, because these people take decisions about local regulations about alcohol, tobacco, leisure time, the leisure industry in their municipalities. This is happening in Norway, in Sweden. They are free to do legislation and regulation at local level, also in England. So this is the hope that we change the system in that sense. Now it seems it's all complementary. These training courses focus exactly there where the others haven't been focusing until now. And obviously, the focus is also to improve the workforce itself so that only people who actually know something about prevention actually do it, because not everything can be manualized. Speaking about these local intervention at municipal level. And this also means we need to change the discourse. We cannot continue with this peace and love and music thing. Wow, we all want to do prevention. Let's stick all together. We shouldn't fight with each other. Everyone should be able to do it. I mean, Zilli's mentioned medical sociology in its history. In order to get from the barber who did surgery, or was the only one who did surgery, to a proper physician, you need to make professionalization. And professionalization means you differentiate from other actors in a way. You define what is this profession and how you get in and when you are kicked out. Or also from getting from homeopathic globally to actually something that saves life. Oscar Cruz, one guy who saved thousands of Brazilian lives simply by buying rats. He said, I buy all the rats that run in Rio de Janeiro, and he exterminated the pest from Rio de Janeiro. And then he put the smallpox vaccine all over the place. This is evidence-based medicine, as we now promote evidence-based prevention. It can be cheap, but you need to distinguish yourself from the goodwill, the good feeling prevention. Prevention is everything that makes us feel nicely. And it is important to call the nonsense by name, like the revolution train, like other things, like other interventions that claim to be effective while the evaluations are just very, very limited. This is highly important. So if I have still time, which I don't have, so I go ahead. An ideal system could be that you have one funding body that has all the funds for prevention, finances a public registry of interventions of programs in the country. The promising interventions get funding for better evaluations. The effective ones that are provenly effective get the funding for large-scale implementation. You know how difficult that is, because in many countries, effective programs never get rolled out. Germany is the main example. And you have a training program for professionals. It can be linked to an accreditation system, but it could be sufficient that you give them the funding only for NGOs that have such professionals in their ranks, and NGOs that implement effective programs. The good news is, this is basically the new plan of the Spanish government to set up exactly these elements in order to spend wisely their money. So the news is not so bad, but they use basically all the tools we are providing: the UNODC standards, the EDPQS, the EOPC training, and the EU minimum standards in order to set up a decent system and cut the nonsense. So what we have been doing, we're just EMCDA typically, reports, basically, and then let people do what they want, make things happen. Now we need to go to a more active approach. Train, let things happen, and see that other things stop from happening. Kind of things like the revolution train. That's it. I end now. Are you still there?
Yes.
Yes, we are.
I was afraid for a second that I was talking alone for the last 15 minutes.
No, it's just the Zoom effect.
Okay. So now we will open it up to some discussion. So we had some comments going on in the chat. I think some of the questions were addressed. It's hard to see everybody. I think we have some. I think that Gregor presented a picture that might be familiar to many of us. I had hoped to would talk a little bit more about the European standards that lay out the competencies for prevention professionals, but I think that it was very well put in terms of what the total system needs to look like, Gregor, and how the different parts have to integrate with one another. And Giovanna has her hand up.
Only after other people have talked and so on. I mean, if there is nobody else, of course, I can jump in as usual.
There's been one person that's had their hand up, whoever 210.
Yeah, let's take that.
Yeah, and Eric Brown also had his hand up.
Okay.
So 210F244C, we don't know who that is.
But please speak.
It's a permanent high five that person has. I just need somebody to.
Well, Eric, why don't you go ahead, and the other person, the 210F244C, needs to unmute anyway. So Eric, why don't you just go ahead?
Okay, well, first of all, great presentations. Really appreciate them. I'm such a fan of both of you. doing a lot of work in Latin America, we're working in a lot of middle and lower income countries, unlike a lot of the higher income countries in Europe and in North America. So we've come to start using the term, instead of evidence-based, because we just don't have programs, a wide array of programs that meet the standards, SPR standards or European standards. So we're starting to use the term evidence-informed. So it's the best thing that we can do given the givens in a particular country. I was wondering if you guys would comment on the use of that term. I know there's some good and bad aspects to that, but I was wondering if you came across that and if you had any thoughts about that.
Go ahead, Giovanna.
I'm happy to comment. So hi, Eric. Nice to see you again, and thanks for your kind words. We have been working in a lot of low and middle income countries, and we have often been using evidence-based programs. And if you adapt them, if you choose them and adapt them carefully, it works. We can discuss more, of course. It is true that it has been sometimes difficult to get access to evidence-based programs that are maybe copyrighted in other countries, maybe expensive, maybe just difficult to access. And it's sometimes downright impossible. I mean, if I'm working in Iran, I just cannot import an American program. And that's why we have been following the great example of the European colleagues that developed Unplugged and put it in the public domain. This was developed with public money, so it's in the public domain. It's much easier to access. Unplugged is a program for schools. So we developed 2 programs for families and really tailored to the needs of low resource settings, so that we would overcome that barrier that you're talking about to using evidence-based program. Now, for example, our program, we are still testing, we are collecting evidence, but we haven't got to the point to do a randomized controlled trial for them. So that's where I would call it evidence-informed. I also call evidence-informed, if you remember that diagram, our ideal is to use evidence-based programs, but not everything can be manualized, as Gregor was mentioning. Maybe you don't have access to programs for whatever reason. And so for me, evidence-informed, it's a very specific way in which I use it. It is practice that follows the characteristics that have been found to be effective in the standards, without having that hard evidence that there is a randomized controlled trial that tells you that that group of activities, specific group of activities, is actually effective. But at least you know that you're going in that direction. I still think that we need to move the field further, like Gregor was saying, because it's just so open to interpretation, and people can be so creative in seeing themselves in the characteristics. So, oh yes, we do that. And then you say, not really, right? And get to the point that Gregory is saying eventually, where really what is implemented has been found effective elsewhere by good level evaluation. Who is delivering it has been trained properly. So I use the term evidence-informed. I promote, but always as with the idea that we cannot stop there. It's just it just opens up too much interpretation to be that useful, to be completely useful, to embrace it completely. We need to move forward further, I think.
Thank you very much, Giovanna. We have we're starting to get a lot of questions. Just wanted to stand in, and I just wanted to, if you can hold a minute, and Sandra. There's a whole issue about the strengthening families 10 to 14. I think one of the things that we need to do, and I don't know, Eric, Gregor, if the SPRs should be involved in doing this, but I had raised this issue at another meeting we had seems like eternity ago, maybe last year. I'm concerned about these different outcomes because strengthened family has been replicated many times, and I think we need to form some kind of groups to bring people together to talk about implementation issues. I've talked to some people for whom the strengthened family did not work because when we talked about who they targeted the wrong age group, and this was a European group. But there are other reasons why they may not be. There might be some adaptation issues that we need to really. That's going to be a huge. I think a huge barrier for delivering evidence-based programs is the whole issue of adaptation. Eric's comment about the evidence, I guess I would call it evidence friendly. This sounds like science-based. Remember the science-based program process that we went through, and research-based. It makes me very nervous. I think this one of the other things that the Society for Prevention Research on many continents, because we have others developing in other countries, is to look at this whole issue of practices versus program. When we were doing this, the international standards, Giovanni, remember I said to you it was like a recipe. We're giving a recipe, but we're not telling people how to make the cake. We're just giving the ingredients.
Oh,
so these are the kinds of things these are big things, hurdles to jump over. But I think we've made so much progress in the last several years. But I don't want to. I can go. Me. I could talk forever. We had Shannon had a question. Shannon Rapp. And Sandra wanted to make a comment. So can we go to Shannon first?
Hello, this is Shannon. I just want to thank you for taking the time to hear me. I have been running a grant for the last 5 years to try to improve SUD treatment services for youth. What we're finding is we have a huge gap between prevention and treatment. And what I see is misuse and early experimentation by youth, but no programming to address those problems. And yes, we can get them into treatment, but most often treatment isn't necessarily appropriate for quite a lot of the youth. So I'm wondering, how can we implement? I mean, thank you. I see Giovanni's already raising her hand. I'm looking for, now I'm writing a new grant that wants to expand the continuum of services and target early intervention and recovery support, which is encouraging. And still there's no model for me to select and really implement it. It's almost going to take imagining something completely brand new.
Have you looked at Project Success, Ellen Morehouse's program?
No.
It's evidence-based. It is a U.S. program, but it's been implemented throughout the country, and it is an early intervention program.
Wonderful.
I can. I'll give you the email of the person in my state, and she's nationally recognized who's implementing it. I'll put it in the chat box.
Thank you so much.
Okay.
Thanks, Sandra. Sandra, did you want to talk? You had a comment.
I did. I am a hero with many hats, but the hat that I'm going to wear this very minute is as the former co-chair of the ICNRC. So we are an international body. We do have standards, and now well, we call it, we have a job analysis, which lists the knowledge and skill sets that a group of subject matter experts believe you need to have. We always have at least one international member on as a subject matter expert. And if we have room for the next job analysis, which is coming up in the next couple of months, I'd love someone from this group to be part of it if I can advocate for that. But anyway, we have had difficulty engaging other countries in our process in prevention certification. And I would love to have a conversation with some folks in terms of how we could strengthen that, because the ICNRC is the only international body that I know of that is certifying people in our profession, prevention. So if there are others, then I certainly am not aware of them, and we should definitely be in touch. We do have some international, we have a number of international members, but most of them are have treatment certification and not prevention. So it would not only enrich the organization and those of us from the US, but I think it would be an opportunity to share information and resources that we don't have right now.
Absolutely. Thank you very much, Sandra. Gregor, you had your hand up?
I think I need to answer some questions from the chat. The exchange database about programs. We always get a lot of shit because people contest a lot the decisions made, but we only take good evaluation studies from the countries. So none of the original, as the comfort version of SFP of the study in Europe could be admitted for analysis even. We could not take any of them. And the other studies, the suite of with SFP 10 to 14, they were from Poland, from Germany, and they showed no clear effectiveness. That's the point. We do not use anecdotal, do not use qualitative evidence. We use evidence from studies that use really acceptable designs. And we have a hierarchy of designs, and we use interrupted time series, for instance, for local policies. So we do talk about policies, I said quite clearly. Not everything can be dealt with manualized programs. That's a very American approach to reality. Here in Europe, a lot of things is being done on local policies at municipal levels that regulate opening hours, the density of bars and stuff, the distance between a cannabis shop and a school, and so on. This is all local regulation. A lot can be done there. And that's why we need to train the workforce, because these things people need to know.
Right.
You cannot train this within a manualized programs. But even these kind of circumscript local programs like the START project in Stockholm and now elsewhere is in our database. We just adjust a little bit the criterion for good and acceptable evaluation studies.
We're finding with our training in APSI UPC that there's what we do in environmental, we'll call them environmental interventions. We talk about policies. People are, professionals are surprised that they're prevention, that we would consider them prevention. It's very interesting. But once they get it, you know, it's like they realize how powerful, if they're enforced, if the policies are enforced. And of course, the enforcement part is the hardest part. So I think you're right. The other area we find, and just to plug out there, is workplace prevention. People also, prevention, a lot of professionals do not understand what they can do in the workplace, and yet you can. There's also putting prevention into treatment. Parenting programs, for instance, would enhance the treatment experience tremendously, and everybody's a win-win, because one of the groups with the highest rates of substance use are children of substance users. We know that it's genetic, 40 to 60% is inherited, but also there's a behavioral, and I apologize for the cat behind me. He always likes to get involved in these discussions. I think we have time for a couple of more minutes. Thank you very much for being, thank you very much for being, hanging in, all of you, for this overtime. So is there any more questions, or did Gregor or Giovanna, did you make a comment?
Oh, don't make me start. I can speak for the next 15 minutes, so it's okay. There is so many interesting things already said. I replied to Shannon in the chat, and we can be in touch if she's interested in further things. I put the standards in the chat,
Oh, good.
just the link, and just would be happy to talk with other people in other contexts for a lot of time, but don't make me start now.
That's okay, because we want very much for you and Gregor to have a prevention talk that's solely on your area that you want to talk about. So we need to set that up in the future. I think I also want to, Sandra, I mentioned that we're having a prevention talk next month on February 11th, where we're going to be talking about workforce development with Tracy and with Julie. Any burning last question, comment? Shannon, you have your hand up. Is that just, you just left it up? Okay. Maria, you wanted to make a comment? Yes, please.
Yeah, I just wanted to say very quickly, I think it's really important to highlight that how the APSI UPC curriculum, and Gregor mentioned the adaptation to the European version, is that this curriculum was the main documents that support this curriculum are the UNODC standards, the SPR standards, and the EDP, the European standards. And through the entire curriculum, you will be able to see, if you go to the APSI International Education Center, you will see how the curriculum relies on the information and connects them both. So you start seeing the theories, the interventions, why theories support the interventions, and then how and what is the best way to implement those interventions following the standards. So we're going to, from the theory to the practice, the science to the practice, and what's the best way. But it's really one of the things that we wanted to highlight through this conversation and through this talk is how important it is to think about these documents that are already out there and very easily accessible to be part of your conversation when you're doing your prevention programming. So it's not, because you have half of the work, it's there. Half of the things that you need to know and you need to do are in these documents. So that was the main point of this talk as well, for you to get them to know better and be able to include them in your process, in your programming, in your prevention programming process. So that's it.
I also wanted you all to see the passion of Giovanna and Gregor, the shared passion that we all have for prevention. I think it is an international. And look at the faces. Look at the people on this conversation from all over the world. It's really, we need to do this together. I don't know how we do it together, but we need to do it together. I think the will is there. So let's do it.
Thank you, because it's very late in other parts of the world.
Yes, and thank you very much for staying up late, for those of you who it's evening. And it is just wonderful to see you all. And hope this is being recorded, so if your colleagues want to hear this, or if you want to hear this again. And hello, Paolo. I hope you're feeling better. Please feel free to pass that on. Okay. Thank you very much, everybody.
Bye-bye.
And thank you especially to Giovanna and Gregor.
Hi.
Thank you.